Good afternoon, our online listeners and the colleagues around. Our online listener, thank you very much for sparing your time to listen to this educative session that is brought to you by Seed Global on how we can approach a patient with chest pain. As we begin our session, I would like to introduce to you as our experts of today that we're going to learn from, that we can easily manage our patients outside there. Thank you. I am going to start with my right hand.
Thank you so much. I'm called Mr. Batista Joseph, a critical care nurse, working CKI Kampala Namwo.
Thank you, Mr. Joseph.
My name is Julia Juma from the Kwame. I'm an EM resident, second year at Mast University.
So he's a senior resident at Mast, is going to give you a very good presentation of the day.
And good afternoon, everybody. My name is Dr. Tracy Volchinsky, and I am one of the SEED educators and an emergency physician at Must University. Thank you.
So you are very lucky to listen from Dr. Tracy, one of the most senior experts. It's going to help you manage your patients very well. Personally, I'm Okelo Solomon. With an MBCHP, I also have a master's in neuroscience, monitoring and evaluation as a student at the same time now for medical law at the same time, master's in anatomy. So it's a very good session that we're going to do today. Without wasting a lot of our time, I come back sorry for forgetting one of our experts is online. That is Dr. Connie. Could you also listen to her in a second?
Good afternoon, dear listeners. I could turn on my video. So this is Dr. Baluka Koni, EM physician with City Medicals. I'm glad to be part of the 98th session of ECHO. And we shall be interacting. I'll be answering your questions in the chat. Feel free to ask anything you want to ask. Thank you so much.
Thank you very much, Dr. Koni. You can see our listeners how blessed you are listening from the senior experts around that has managed our patients very well. Without wasting much of our time, the team in here would want to listen to some of the expectations of the online listeners. It's easier always to approach a situation if you have an expectation of any given situation. Could we please listen to 1-2 people give us our expectations, please? Could you please raise up your hand and we move on? Raise up your hand, please. Our listeners, none of you has an expectation today? Here, at least all of us are medical professionals. You must have an expectation. Every patient you're going to approach is always a target. And so that is the expectations we also get from you today. Okay, could I just pick 1 or 2? Stuart Mugume, could you please give us a brief of your expectation? Mute and unmute and give us a brief of it. Just a second. Yeah, looks like Mugume is a little bit far. Can we get someone else? Albert Mugisha? At least, please, listeners, could we give some energy to our experts to give us the best they have for us today?
Some have put them in the chat. You could probably go through the chat.
Yeah, looking at the charts, there is the Timothy Mugabe expects to get the difference between chest pain caused by cardiac etiology or respiratory etiology. Yeah, thank you. And we have Charles. Charles wants to know the difference, the differential diagnosis of chest pain, and you're going to get the best today. We have Hassan to have a clear path of how to approach a patient with chest pain. Thank you very much. You're going to have the best today. So think we have someone, that's Joseph Katumba. Joseph, please could you unmute and give us your expectation in a second?
Hello, can you hear me?
Yes, we can hear you clearly.
Yes, thanks for having me. Quick one. We always under unlimited resources, so I would want to, at the end of this session, to be able to manage that patient with limited resources. So we know we work with resources that are not up there. So I would want to see at the end of the session, how best can we handle such a case even when we do not have enough required abilities within our own setting? Thanks very much.
Yeah, thank you very much. You are going to get your question answered fully. We have the most senior experts going to talk to you. There's Beatrice. Could you please unmute and give a brief of your expectation of the day? Beatrice. Beatrice. Yes, Beatrice. Beatrice, I think it's still getting, could be network issues. We can go to, we can have Osele Emmanuel. Osele Emmanuel, 2 minutes, 2 seconds, I mean.
I am actually excited for this whole thing because chest pain is a very broad thing. I can't imagine how we are going to deal with more than, I think, 10 cases, how we are going to break it down. It's more of like an algorithm of how we are going to break down more than 10 cases into this very short time. I'm excited for this. Best if it's fit into like how statistically it deals with our own population and what most we should look out for and what not to mind so much.
Thank you very much. Thank you very much. You're going to get your question answered. We have over 100 chest pain causing etiologies, but we shall have to get the best way to approach our patients in emergency situations. We don't have any other person to give us session. Please could allow us move to the next session. That will be a case presentation. Please, Dr. Julie, could you give us these very good presentations from a patient that will manage, please? Thank you.
Good afternoon, everyone who joined us. I'm happy to be here today presenting the case we're all going to discuss and use it as a pathway to dissect chest pain. So without further ado, I'm going to present a 58-year-old woman presents to the ED with 3 days history of sharp right side chest pain and cough with progressive shortness of breath. Now I will ask the audience, considering the diagnosis of or the complaint of chest pain, we can have a pool of, and you're gonna tell me which one is less likely to be. All of but one are important differentials that must be excluded. So you have the pool, and waiting for your participation. So yeah, I want you to focus that which one is the least important in all this diagnosis. Which one is the least important?
Yes, our audience, these are the questions on there. Thank you. Give your responses, please. From this, you can find the biggest number. It's talking about the costochondritis, and there's also a very good group talking about the acute myocardial infarction. There are people talking about pleuritis and pneumonia. Have about 6 people talking about aortic dissection. Thank you for thinking very well. In this case, we say there are a number of differentials for chest pain. We also have about 14 people out of the 108 people that have here talking about deep vena thrombosis, stroke pulmonary embolism. We have 2 seconds to complete our responses, please. Give your response, please. We want to get to know this. We see how we can approach these patients of ours. We are doing great so far. Our session for the responses is complete. Could we get to know from the presenters more what she can bring? Thank you.
So next, we go to the primary assessment of the patient in the emergency. Her airway was patent, protected, but patient was breathless and unable to finish sentences. She had marked distress on breathing with accessory muscle use. She had shallow breath, equal chest expansion with respiratory rate of 31 per minute, SpO2 of 85 on room air, and trachea was midline. She had dullness on percussion in right lower zone and reduced air entry with pleural rub at the same zone. Her capillary refill time on circulation was 2 seconds. She had cold extremities. Her peripheral pulse were regular, weak, but synchronous. Pulse rate was 115 beat per minute. Blood pressure was 100/60, and she had normal S1 plus S2. So I would like 1 or 2 people to tell me which ones are abnormal.
So back to our listeners, we give a quick response to this from the survey, primary survey of the patient in presentation above. Could we please do this first so that we get to learn the best today? Thank you, our listeners. Could we please give our responses? Some people have raised up their hand. I'm seeing Castro. Castro, unmute and give a brief response. 1 second.
So A and B, I mean A and C seem not to be very bad. However, the problem is in B.
Okay, what is seem not to be very bad? Could you talk about that? Which is that small, very not bad, maybe not very bad, but bad.
The fact that he's unable to finish sentences and breathless means still point towards a B. And since we have features of increased work of breathing in B, the lowest SpO2 and a dull percussion note tells us really that the man might be having fluid in his lungs.
The man might be having fluid in the lungs. Thank you very much for the response. I like the response. It's really very interesting. Any other person? If we don't have any other, we could listen to. Is this Oriba done? Could you give a brief response to this? Thank you. Unmute.
Thank you. Thank you very much, Chair, and the team for this wonderful topic. Normally, during our ward round, I always tell my colleagues that this this patient has presented excellently, and you need to feel the feet of a patient in shock. Those with the cold extremities or those with the cold feet, okay, those with the warm feet ideally do not have cardiogenic shock. So when you feel someone's feet is cold, especially in emergency, and they have these parameters, you should definitely go for cardiogenic shock. And then you look for features of cardiogenic shock. Is it obstructive myocardial infarction? Is it pulmonary embolism, which is causing the heart failure or the shock in this patient? So it is actually in that line, but this is obstructive myocardial infarction, probably with the chest pain. I don't know. But there is also PE, which we think can still come in. But definitely the patient is having a cardiogenic shock. Thank you.
Thank you very much, Mr. Rip. I'm very grateful. We are really very grateful for your response. You are really thinking very broadly. And from whatever you presented, I'm sure the listeners have got it, and the presenter will still continue, and we shall get more of this patient's presentation. We shall make a very good diagnosis and manage our patients. We shall respond all, please.
So continuing on the primary survey, on disability, she had a random blood sugar of 7, the LESCOM score of 15/15. Patient is awake but anxious. Her pupils are equal and reactive to light. On exposure, her temperature was 38. She was in pain that she scored 8 out of 10. And the patient was sitting upright, unable to lie flat. She had mild cyanosis of lips and nail beds with mucous membranes that are moist. Now, this is a very interactive session, so we go to our second poll. What are your top 3 priority management for this patient as far as we told you the case now?
Back to our listeners, we say it's going to be very interactive. We are going to understand all this together. Could you please unmute and give your response to this? The immediate management for this patient, what you're going to do for the patient. Thank you. Can raise up. Yeah, the responses are really coming very well. We can see a good number of people talking about antibiotics, oxygen, and vasopressors. A good number of people as well. There are about 5 talking about aspirin, ECG, and fluids. About 13 people, which is the highest number, talking about oxygen, analgesic, and fluids. About 3 people are talking about giving this beta blocker, oxygen, and analgesia. Then we have about 5 talking about giving adrenaline as a vasopressor, analgesia, and oxygen. Thank you very much for this response. We have seen the biggest number of people talk about oxygen, analgesia, and fluids. Could we please get back to the presenter again? We shall get all this knowledge, please.
So our top 3 priorities for this patient was first hypoxemia as evident by SpO2 of 85% of room air, and the inability to sit up, inability to lay down, sorry. The associated with a risk was the tissue hypoxia and anaerobic metabolism. The immediate action taken was oxygen by face mask at 10 liters, and her oxygen improved to 94%. Our second priority was the pain and fever. Her temperature was 38. Her pain was scored 8 out of 10, which associated risk was the shallow breathing, anxiety, discomfort, and increased metabolic demand. So the patient received IV access of paracetamol 1 gram IV. The third priority was the hypotension. Her heart rate was 115 with blood pressure of 100/60, which threatened to have decreased the end organ perfusion, which she received IV fluids for. And always remember to reassess and monitor response to treatment. So what happened in the ED to stabilize the patient? She received the 10-liter oxygen, aiming for 94% saturation. She had a second IV access, which she received ceftriaxone 1 gram IV and morphine 6 milligram IV for pain relief. She also received normal saline 500 ml per hour and urinary catheter to help monitor fluid balance. On her sample history, because now you will manage the patient and the patient is stabilizing, you can have more time for a thorough history. So on our sample history, she had sharp right-sided chest pain, worse with breathing for 3 days, with productive cough and yellowish sputum with streaks of blood. She was seen in a clinic 2 days prior to admission and given oral antibiotic. We don't know which ones. She wasn't non-allergic to any substance. She has medication. She was on medication, amlodipine 10 milligram, prenopril 5 milligram, and metformin 500 milligram twice daily. On her past medical history, she's non-hypertensive for 8 years. With normal blood pressure, her normal blood pressure is usually between 140 to 150 over 80 to 90, which take us back to the blood pressure initially taken at the ED, make it markedly low in this context for this patient. And she also was non-type 2 diabetic patient for 10 years. And she gravid 7, para 1 plus 6. There no history of TB or non-exposure, and no sick contacts, and no history of cardiac event or surgery. Her last oral intake was 6 hours prior to admission. So in the events leading to the presentation, she developed the cough, the pain, the chest pain, and the mild fever 3 days ago, with severe shortness of breath on exertion on the day of admission with worsening pain, which prompted the ED visit. Had been well recently, visiting relatives in Yombe and returned just prior to symptom onset. So on secondary survey, head to toe, the relevant positives, because it's a long survey, the patient was sitting up uncomfortable with mild peripheral cyanosis, tachypnic and hypoxic with pleural rub and reduced air entry on right side. She had tachycardia and hypertension with left leg swelling. The negatives were she had normal conscious state. She had no raised GVP, no lymphadenopathy, no wheezes, no tracheal deviation, no sign of chest trauma, no neurological deficit, no skin lesions. Now, before we investigate these patients, what do you think the differentials could be?
So back to our listeners, could we generate differentials for this presentation that has been so detailed? Please, you could unmute and put up your hand, unmute, and give us your differentials, please. We have a good number of listeners, over 200 at least. We can give brief. We have those who are typing. We have Sharon talks about pulmonary embolism. Philip talks about DVT. Serwata talks about pulmonary embolism. Martha talks about DVT, stroke, pulmonary embolism. Someone is complaining about volume. Please. It's okay. Someone talks about complicated bronchopneumonia. There is Kate talking about possible PE. There is PE. We have ready to talk about PE following DVT. We talked about Napoleon thinks it's PE from the presentations. Here, Yeah, there are a number of responses here. We have a number of responses. Thank you for all these responses. A good number of you have talked about PE. Thank you for this response. Could we go back to the presenter and give us a brief details of more so that we can manage this patient? That will help us manage other patients as well. Thank you.
So, thank you for all the responses. They were almost point on. So the category of possible differentials, there's a lot of differential for chest pain, but it can be vascular, infectious, trauma, autoimmune, metabolic, heterogenic, or neoplastic. So the vascular is the PE, MI, and aortic dissection. Infectious like TB, pneumonia, pleuritis, pericarditis, and costochondritis, and herpes zoster. Trauma or toxin like rib fracture or pneumothorax. Autoimmune like SLE, Good-Pastor syndrome, prothrombotic disorder. We also have decay and uremia as metabolic causes, and heterogenic like medication error. Neoplastic like lung cancer, metastatic cancer. And let's not forget all the differentials with the epigastric, epigastritis, gastric reflex. So we move now to another pool. We love giving you polls. We like you interacting with us. So of the following choices, which investigation best represent key investigation that would most likely change the management for this patient?
Our listeners, again, there are those responses you give them on your screen. Could you please give your responses? We have 3 minutes. At least if all of us could give our responses, that would be very important, because it's been a very detailed presentation. At least you can get what to do. We have a very good number of people talking about doing C-reactive proteins, chest X-ray, and ECG. We also have a very good number thinking about doing a D-dimer, CBC, cardiac echocardiogram. Very good number thinking about doing the chemistries, arterial blood gas, and CTPA. A very good number also here, about 5 of them thinking about doing a culture of this blood, Doppler ultrasound scan, bilateral limbs, and some cardiac markers here, troponin. We have a good number as well also thinking about doing a CT of the brain and CT angio and the D-dimers as the immediate investigations they would do. Could we have about 30 seconds to complete this? Let's continue giving responses. So we are really very happy about this. That means we are learning so much on our approaching patients with chest pain. Someone talked about how many cases we're going to talk about. We said we're going to discuss how we can approach these patients in emergency situations. We keep them alive, and I'm happy we are learning from the senior experts we have. We have about 10 seconds to complete this. Could we do it? About 5 seconds. Could we continue responding? Thank you very much for the responses. Could I hand you back to the presenter to see more comes that we learn? I'm very happy we are learning very well from the first presentations to subsequent ones. That means we are learning. Thank you.
So thank you everyone who responded, being so responsive and awake. So on blood test, we did multiple tests. Full blood count showed a total of 14,000 neutrophilia. Hemoglobin was 11, her platelet was 160. Her malaria RDT was negative. Her RBS by lab was 7 millimole. ECG we're going to discuss on the next slide. The electrolytes, her creatinine was 1, urea was 23, the potassium was 4.0, sodium was 140, her troponin was 0.5 with a normal range for the lab from 0 to 0.3. ABG unfortunately was not doable. CRB was 46 milligram, and the blood cultures were drawn and pending. So another pool, which is the following, is a component of the Wilson score for assessing the probability of pulmonary embolism, which is part of that score.
Back to our online followers. We are very happy you are learning a lot. Now the well score, you can easily manage these patients of ours. Could we please give response to this? There are very many already have looked at elevated D-dimers. A good number responses here are flowing very well. You can see that we are really learning so well. The experts here are very happy for your responses. Recent surgery or immobilization. Others have also seen the low oxygen saturation on room air. I've seen about 10 talking about the sudden onset of severe chest pain. And about 5, I've also seen this family history of thromboembolism. We have about 30 seconds to complete the responses. Thank you for bringing all these. We are really happy that the time of the presenters here are not wasted because of your learning so well today. Thank you. We shall be very happy to have a very healthy Ugandans and world at large. We have about 5 seconds to complete our responses and yeah. We are really very happy that we know these emergency scores to even manage our patients well. A well score is one of the scores that is used very commonly by the emergency physicians in emergency situations, and we are happy you've learned this. Thank you very much. We have come to the end of that response. Could we go back again to the presenter to give us more as we learn? Thank you.
So this ECG. Could I get a quick one answer? If what you see on this ECG, what's abnormal about this ECG?
Back to our listeners. Now, the senior cardiologists to come and give us. You can give a brief response, a quick response to this. Very clear ECG. There is no excuse about it that have not seen those waves very well. At least we can see all this and pick something. Thank you. The experts are really doing so well and to help us learn this. Thank you.
Just a quick response.
Just a quick response for anyone.
The ECG.
We have a hand here, Doctor. We have Dan Lagoya. Could you unmute and give a quick?
Yes. Thank you. Thank you very much. I wanted to give opportunity to other people to respond, but what we see here is a sinus tachycardia, which is you see the P wave in lead number 2. There's also P wave in lead number 3 and AVF. This one shows you that the rhythm you're dealing with is sinus and is coming from the sinoatrial node. The sinus tachycardia, together with the history of the patient, points towards pulmonary embolism because it's common in patients who have PE, about 97% sensitivity, but not specific. Now we go to lead number 1. You see a very, very prominent S wave in lead 1. Okay. Then when you go to lead number 3, you see a very prominent Q wave and T wave inversion in lead number 3. So when you have S1, Q3 and T3 is common in patients with PE and normally in about 10%, but normally it shows you that it's probably massive. And then look at V1. I hope we all see what is happening in V1. The R wave is very tall there. And so that one shows you features of right ventricular strain. Normally, it occurs when you have bowing or straightening of the intraventricular septum in patients with the massive PE. So I think this ECG is highly suggestive of pulmonary embolism. Thank you.
Thank you very much, Mr. River. You must be a cardiologist, and SID Global is really very happy for you. We are waiting to see the next pulmonologist as we continue. Thank you very much.
Thank you so much. I don't think I can add anything on that. That was perfectly done. So yeah, the ECG was highly suggestive of pulmonary embolism. Next, here we have bedside point of care ultrasound done to the heart. This is a parasternal view. And as you can see, there is a D sign, which means that the proportion of the right ventricle to the left ventricle is massive. And it's highly suggestive of a PE. Also here, we can see at the right lower zone, we can see air space opacity that's obliterating the right costophrenic angle. And in this context and in this patient is suggestive also of a pneumonia. 24 hours later, we managed to get the CTPA, and you can see here is the pulmonary vessels, and then the gray part is the pulmonary embolism. Yes, that's the pulmonary embolism. So now we move to the supportive management of this patient. We put the patient in 45 degree to help her breathe better. And we gave her paracetamol 1 gram IV to be taken 3 times a day, and pantoprazole 40 milligram. We monitored the blood sugar with meals and maintenance fluid until she was able to drink. Her specific management, now we can see we have 2 pathologies intertwining in this patient. We have an acute PE and we have community-acquired pneumonia. So for the acute PE, the continuous oxygen support, apixaban 5 milligram or enoproxene 1 unit kilogram per PD, and we aim to that the patient will stay pain-free. For the community-acquired pneumonia, we started her on levofloxacin for 500 milligram PD and paracetamol infusion for fever control. 24 hours later, the patient was still having ongoing oxygen requirement, but it reduced from 10 to 8, with still maintaining 94% on 8 liters. Her blood pressure improved to 120/60. Her heart rate now reduced to 100, and she was able to lie flat. Now, but now the sputum contains clots of blood, and she's still requiring regular pain relief. The specific management or disposition plan was that since the CTPA confirmed PE, we start anticoagulation and then discuss the role for thrombolysis and involve the ICU team because this is an ICU patient. CBC, CRB, and chest X-ray, possible pneumonia. We started the empiric antibiotic ceftriaxone and waiting for blood and sputum cultures. A GeneXpert test was negative, so no further management was required. So thank you so much. Now we move to my colleagues.
Yeah, thank you very much. The presentation was such an intelligent presentation and enriching, and we've learned about the PE management and pulmonary embolism, the management. That patient was approached clearly well, and we are very happy, Dr. Julia, for that. The next session will be pre-hospital in facility care and the interfacility care of a patient with a chest pain. So we shall really be very happy to get into the next session that will help us manage our patients to the best. Doctor, thank you very much and you're welcome.
Thank you very much. My name is Joseph Senkumba. Apologies, I came in some minutes late. And I would want to also give a contribution to this patient, but also mention some general stuff of what we ought to do as pre-hospital care providers. So I'll start with the arrangement. We will talk in my discussion in a few minutes. We will talk about what kind of stuff, how would you want to manage the patient, which kind of equipment you want to prepare, some of the medications, and of course, what is the suitable mode of transport for such patients. And we will talk about briefly about handover. And the next slide, patient with PE, for me, if I got such a call, I would be very tensed. And in my opinion, or in the opinion of the school where I have, or the schools, the school of thoughts, who needs to be on this ambulance if you have the luxury to have a Tracy on board is one of the people you want to alert and be part of the ambulance team to move this patient. So physicians are really very important. If you have a critical care nurse or someone with a very good experience with respiratory therapy or something like that, it would be nice to accompany this patient. Also, as an EMT, this is a case that you need someone who is more advanced, maybe not really a basic EMT. An EMT advanced would be better to transport this patient with the ability to provide advanced life support. Yeah. If you cannot get the physicians or these people, it's better you are at least on call with them and you are all the time in contact with these people. So part of the equipment, of course, this might not be all of it, but in my thinking as Joseph, I try to put my equipment, trying to see what can escalate and what will I need possibly, and depending on the environment of the ambulance, what can I possibly do? And I arranged my things in the order of A, B, C, D, E. I would anticipate if this patient gets unconscious, they need to be protected. And at my level as an EMT, I would go up to an LMA, but also I would pack my ETT and other things for advanced care. At B, I have to check my oxygen. This is a patient. I do not want to go with an empty ambulance. I would go and check if my 2 cylinders are actually full, depending on the time I will use to transfer the patient, or if the patient will need support, think of a ventilator, think of a bag valve. Mask will come in handy, and of course the accessories to deliver oxygen. At C, this ambulance should have actually a monitor, the possibility to do ECG. 6 lead, 12 is the best if you can use it. But if you don't, maybe 4, 6 can work. And we have to keep monitoring the pressure, keep monitoring the oxygen saturation. So please make sure that all that equipment actually works and is available to transport such a patient. If you have the luxury of nice equipment, is actually not luxury, but you need to have a possibility to defibrillate the patient if they deteriorate, or maybe they go into a cardiac arrest. So you have to have at least a defibrillator, whether manual or an AED, for example, for EMTs can work handy. Maybe the rhythm might be a challenge, but with good training now, we can use the manual defibrillators in the ambulance. Also think about IV access and all those accessories. When we go to D, I want to keep monitoring my pupillary reaction. So my pen light torch should be on my uniform or just near where I am going to work from, my glucometer, to try and continue reassessing the glucose. And of course, in E, keeping the patient warm. So I'll need a thermometer to be able to know this, and of course, a blanket in some of the things. So there are things as ambulance providers and pre-hospital care providers, we ignore that sometimes are so huge. For example, we do not most times check if our equipment is charged or if the power points are charged. For such a case, you really need all your monitors on without anything going in a mess. Air conditioning can also help you to create a warm or cool environment versus maybe a blanket and other things. And our patient here has, I am thinking at the time I'm transporting them, they still have a fever or it was managed. But in case they have a fever, you would also use your ambience of the ambulance to create a more cool environment for the patient. Check that you have the possible PPE, check that you have the bins. And of course, if the ambulance has the wash facility, many of the ALS ambulances would have the wash. And check your lighting, and of course, the stretcher bed has to be functioning. This patient is telling us the position they want, so it's important that you have a functional stretcher bed. And most importantly, in Uganda here, and people listening, ambulance drivers and pre-hospital care providers, please make sure fuel comes before you get a call. So all this is preparation. Don't think of fueling when the case has come. So you need to have fuel earlier. I would go on the next slide, thinking of the medication. Of course, we go slow on medication, and we are always under guidance of a physician or medical direction. But on this ambulance, I would really want to check if I have any anticoagulants. I want to check if I have any vasopressors, and I can also think about the medications in cardiac arrest. So because you will be on your own from the facility where you pick the patient or from the home until you get to the hospital. So you need to think of the worst. When the worst comes, the worst, so I can put my adrenaline if I have to now resuscitate the patient along the way. And the biggest drug here is oxygen, really. You need to make sure that you have oxygen. And whenever you want to use drugs, make sure that you know the protocols, you know the problems of the drugs, or you are sure. If you are not very sure, please ask. Please ask. I will always call my supervisors of my medical director to ask about a dose, to ask about the timing of the medication. A patient with a PE, especially if it is critical, and in this case, when we saw the images, it seemed like a big challenge. So this is a patient you want to transport very quickly to definitive care. And in other countries, here in Uganda, it's starting. As a patient you want to put on a chopper if they're coming from Barara to Kampala, if you have the money, because they have to get to the higher level facilities early enough. So I put for you some nice images of Ugandan providers of air medic, air vac that we can use. So don't limit your options because you only know the ground ambulance. So if you can suggest some patients at a high level and they can actually afford. So please think of air transport would be the ideal for long transport, but if you have shorter transport, maybe 20 minutes, 30 minutes, you would think of a Class C ambulance. For me, that's what I would recommend. So this is a Chibi ambulance, and I'm sure government has procured very many and more nice ambulances that could transport such a patient. So a Class B, Tracy can tell us, you may fight a lot if things deteriorate. So you would better think about the highest level of ambulance vehicle available or ambulance mode. Now, you see, from my job as a pre-hospital person, I follow the style of life. Most of the first things that you do not see there have been done, and now someone detected that there was a problem, there was early reporting, I have been dispatched, I have come to the scene. So what do I do when I reach the scene for this particular patient? I will definitely need to get some background from the team that is taking care of the patient. But I also, as a person who is going to do the continuous care and supporting to transfer, I want to have my own opinion about the patient. So I'll try to quickly repeat my ABCDE. It's very important. Every day here we talk about ABCDE. If you don't know it by now, we should now, I don't know, do what to do. But always make sure that you have an airway patterns, and cautious patients should be helped to protect their airway. And for breathing, please look, listen, and feel. You can use your hands before you even use the equipment, but it's also important to always continuously reassess. This is a patient I want to reassess every 5 minutes because they can change and anything can happen. This is a patient you want to put an ECG on, and you transport them with it all the way through. And it's a patient I want to ask the position they want to sit in, and I'll make sure that I'll do that. Earlier, doctor mentioned that they were comfortable in at 45 degrees. I will try to achieve that with my stretcher bed in the ambulance. And of course, I might have to ask either medication to move with. It can be prepared for me, or the doctor can give me some clues or when and what medications to give, either along the way or before we set off. I want to keep an eye on the mental state of my patient, the glucose levels, and of course, trying to maintain the temperature of this patient on scene. So as we move, care continues, like I mentioned. So inside the ambulance, I have loaded him. Now, for example, it's very common that we shall use a ground ambulance, got a class C. I'm very lucky from Mbarara. I don't know where this patient was. Was it Mbarara? Apologies. So I will need a class C ambulance, and I know that that journey will be a bit long. So I'll prepare all the drugs from the team. And during transit, I'll continue ABCDE. I'll continue monitoring. If you could show the next slide. Thank you. So here we are continuing care. No. Again. Yes. So here, like you said, we perform continuous patient assessment and monitoring. And remember that when patients sometimes move, certain things in the body can change. So keep your eyes onto the monitor, keep your eyes onto the patient, keep reassessing on your patient. Make sure that oxygenation is a priority. Always target at least 94 or 95, above 95% of saturation. So I would keep my eye there, keep on my administration of oxygen. And of course, I want to keep the monitors on the patient all through. And I have to always make sure that I see the changes in the rhythm that are displayed on the monitor, because you may not realize that the heart is actually now becoming something else. So your eyes should be always on the monitor and keep recording, keep reporting the changes to dispatch, to medical direction, but also to where you're going. You need to inform them about changes of the patient. And of course, if you don't manage pain, then you will go through a hassle with the patient. So continuously manage pain when the drugs wear off, of course, under direction. And it's important to check if the neural state of the patient keeps on changing or improves. This gives us a good idea of the patient we are transporting. And finally, it is our role, and of course, role of dispatch, role of medical direction, but also us in the ambulance to make decisions on where the patient eventually goes. So you do not want to go knocking hospital emergencies with a patient you have not told them about. They will keep pushing you. We don't have a bed, we don't have those services, you go to the next hospital. So you need to think about transferring this patient, and that decision is also part of medical care. That you use your time very well and talk to the people who expect to receive this patient. Tell them about the history, tell them about the changes, while in transfer, if you have done any kind of interventions along the way, please keep them in the know, and of course choose a high-level facility for this case. Definitely a facility where we can get a catheterization laboratory or an ICU and other services. And when we reach the people, you need to talk as medics at your level. At my level, I would want to use an SBAR to tell them about how I have seen the patient, what kind of care I've given them until I hand over the patient. So you can give both a verbal and a written handover. And I am lucky that the presenter had already identified some things in the SBAR which you could mention. So that is my contribution. I am still available here to answer some questions. I am happy that I am discussing this topic with very senior people, and we will get through the way. And I say hi to all my pre-hospital providers watching.
Yeah, thank you very much for that presentation, Mr. Joseph. I am happy the listeners are really getting all this to the best of the management of the patients in emergency situations who have presented with chest pain. We are very good at managing time as Seed Global, so we want to go to the next session that will be presented by one of the most senior EMT, that is Mr. Joseph. Thank you.
Well, thank you so much, the team around and everyone watching to listen to us from wherever you are. Once again, I'm called Statista Joseph. Now working in CK Healthcare, ICU department. So with this patient, when you receive a patient, the first thing to do is you have always to make the nursing care plan, because that will precise the medical diagnosis that you already know. These patients have also got their nursing diagnoses that will always try as much as possible to address them. So it is important that when a patient comes, when you look at their vitals, first of all, it will tell you a lot about the patient, the temperature, the blood pressure, respiratory rate, all that around, you know. It tells you what the patient needs, the requirements that you need to address in this patient. So an example where we're having a 65-year-old female who has been who's a patient known with a history of hypertension, hyperlipidemia, recent immobilization due to surgery. They arrived at the emergency department reporting certain onset of chest pain, shortness of breath, with increased tachypnea, heart rate, also reduced blood pressure around 90 over 60 millimeters of mercury. The saturations are low, below 90, which is 85%, and room air. Then the temperature is okay, which is 37. The GCS may still be okay. Okay. Then this patient also goes ahead and it tells you that, you know what, I've been feeling nausea and vomiting. So for the past 4 hours, 3 hours, I've vomited 4 times. And it tells you that he has no any known allergies or history of any substance abuse. So what we consider here is we want to address the patient's needs at the moment. So the first thing to do is, given the fact that the blood pressure is very low, so it means that there is poor tissue perfusion. So the blood may not reach to all vital organs. So what you do, as they call, is have to restore the saturation, at least with a minimum mark of around 65. Okay, so this one gives you assurance that the patient's circulation, blood circulation to vital organs is going to be assured. So what do we do in our plan? One is we have to give fluids, okay, if they are not restricted. But sometimes where fluids may be limited. So we have to give fluids. And then the moment that we said maybe the response is not so quick, doctors always prescribe inotropes and vasopressors. And my colleagues talk about emergency medication that they move with. We have adrenaline, dopamine, butamine, all those ones. So if you see that the patient is not responding maybe to fluids, then we go to another option. Okay, so when you give this medication, it will depend on the patient's needs and how the patient is responding. So your goal is that all the rationale in you is that make sure that the brain and vital organs are well, they receive blood, okay, well perfused. Then after time, you also have to evaluate what you have implemented. How is this patient responding? So maybe after 2 to 4 hours, then you find out that the blood pressure is now normalized 120/80. So with a mark of 93, and that would be a good achievement as a nurse. So besides that, this patient also has got impaired gaseous exchange, okay, which is related to poor oxygen supply because of the reduced cardiac output. It is evidence to you as a nurse with this with increased respiratory rate and shortness of breath that you are observing in this patient. So your goal as a nurse is to make sure that you improve the oxygen saturation, okay, by administering oxygen. So it will depend how the patient responds. We have different steps of administering oxygen using oxygen equipment. We have nosoprong, non-rebreather, we have high flow, and then we have non-invasive ventilation. Then also we have invasive ventilation. So when seeing this patient, actually the patient will guide you on what they need. So the goal will be is for you to improve oxygen supply to the patient. So administering oxygen at least targeting above 95%. But if a patient has got maybe a history of a respiratory disorder, for example, COPD, then at least if you achieve 90%, that's okay. So then as a nurse, you have also to put in mind that this patient is breathing, but it's using a lot of efforts. So what you do is you have to reduce the respiratory effort, the workload, such that they don't get tired. Besides what they're having, you talk to them, you calm them down, you counsel them, okay? So this one helps the body to reduce the oxygen demand, okay? Because now they are relaxed, they are resting, the demand for oxygen will reduce, and there we shall achieve the best of this patient. So as we continue, this patient came in reporting with chest pain, severe chest pain, giving you 8 of 10 on the scale of 0 to 10. That means despite that you are intervening in giving medical care, also nursing care comes in here as part of patient care, because work as a team approach. So what you do, you administer pain management as prescribed by the physician, okay? So in this case, we can give morphine, 5 milligrams, okay, IV, then we give it time. So morphine it's an opioid. So it helps reduce pain, but also it calms this patient down. I think you have noticed that in most patients with respiratory concern, maybe in cardiac infarction, they give it morphine. So I know as a team, you get more explanation as we go on. So the goal is help this patient feel free from pain. Then, if the GCS of this patient is reducing, okay, the class common scale assessment, as a nurse, you must be concerned, because any patient with a lowering GCS is at risk of aspiration. Okay, so your assessment is very vital in protecting the patient airway. One, if we know that this patient can easily aspirate, we don't want to orally put them into danger by giving them oral feeds or oral drinks. So passing NG tube is very vital for this patient because it will help you protect the airway and so much more. So that is how we can approach this care to this patient. And for more, you can always search if you want anything care plans. We have the links that are given you. And NANDA, which has been our reference. Thank you so much.
Yeah, thank you very much, Mr. Joseph, for that nice presentations. I'm very happy the teams that are listening are really learning a lot on how we can approach our patients with a chest pain. We are very lucky we are having many Josephs today. You know, Joseph in the history of the Bible, if you read very well, you will be blessed. At the next session, I'm seeing very many questions being put there. We shall answer them at once, all detailed, and you will have learned. The next session will be presented by one of the best physicians as in terms of emergency you would have. My teacher at undergraduate made me pass the thing very well, and I was really very happy. So you can listen to her. She's going to give you the best you would want to have in terms of emergency approach to patients who present to you, and you'll be called one of the best physicians in your areas of jurisdiction. Thank you very much, Dr. Tracy. You are welcome. And the listeners are very happy to listen to you and learn the best from you. All the package. Thank you.
Thank you. What a wonderful introduction. I hope I can live up to the standards that has been set by me. I also want to recognize the enormous amount of expertise that we have online as well. And I'm quite humbled by the contribution that we've had to date. I actually think that the pre-hospital team, nursing team, and the case presentation have done a very good job about the assessment of the chest pain patient and the initial management. So I'm going to take a slightly different tack with my talk. So let me just make sure I'm on the right screen setting here. Okay, so I'm going to run through some of the less clinically specific but really important reasoning aspects behind how we actually approach chest pain. So the first thing I'm going to ask you is a poll, because we love our polls, yes? Now, don't think too long and hard about, but have a read through this. Which of the following best illustrates the concept of diagnostic momentum?
Back to our listeners, you have a poll on your screen. Could we have a brief 2-minute session of response to that? Thank you. We're already seeing responses here for clinical misses, rare diagnosis. Due to lack of experience, we have seen patients with patient's diagnosis is prematurely concluded. Yes, please. Could we respond to that? Yes, your responses are being noted. You're doing so well so far. Thank you. Over 100 have responded already. The other 200, we can also give some responses. We are now emergency physicians in this context. Thank you. We have about 30 seconds to these responses. That's great. Yeah, thank you very much for the responses. Could we get back to the presenter to give us more of the information? Very good number of you have responded, and very good. You've learned a lot, and you continue to learn a lot from the best.
Okay, so great. I'm very happy to see that there was quite an even split, but definitely there was people there that were paying attention and managed to give a good explanation. And I'm just going to delve into that a little bit more, because this is an element of what we call cognitive biases. And cognitive biases are very important to the way we practice medicine. So these are systematic errors that occur in our thinking that aren't completely random, and they're somewhat semi-predictable. And they have a significant influence on the way we interpret the information, how we gather information, make diagnoses and treatment plans. So I highlight this because in this particular case that we talked about, this lady came with a diagnosis of a community-acquired pneumonia and had stayed being treated as a community-acquired pneumonia. And it wasn't until they got a disruption of that diagnosis and a reassessment that we were able to actually change track and come to the correct diagnosis and a completely different treatment algorithm to follow. There are many cognitive biases in medicine. So one of the ones that we're often fall victims to as busy decision makers is anchoring bias, when we rely too much on the first piece of information we get. So we knew this patient had been put onto antibiotics. So we go, well, she must have an infection. It is the same as if you saw a car. If you first saw a car for 30K, you'd be like, too expensive. But if it was the first piece of information you got, was this car was 60K and had been discounted to 30K, that is actually going to change your decision-making process about that car. Another very common bias that we fall prey to is confirmation bias. So if I asked everyone in the audience to picture an animal in their head, this animal has fur, they have a tail, they have 4 legs, it eats mice, it's a wild animal, it does not meow, it has short legs and a long body. What is in your head? Okay. If I was to say that you were thinking of a cat, that is possible, but I wonder how many people were also thinking about something like a fox, or I see a badger or a stoat. So really, it depends on what you are paying attention to and what you emphasize in that history as to what you pull out of and what type of diagnosis you end up making. So Sherlock Holmes or Arthur Conan Doyle famously said it's about finding facts to fit your idea rather than actually being unbiased and weighing up the information that is actually in front of you with the patient. And then the last piece of information that I'm going to talk about was diagnostic momentum. This is quite a dangerous bias that creeps into our practice. As soon as you write on a piece of paper or an EMR a specific diagnosis, it is really hard for that person to shake that diagnosis, because that is what gets handed over to the next person, and then the next person, and the next person. So it takes discipline to undo the work that has been put in front of you. So that is just a really quick sort of important piece of what we do as informed clinicians. And I wanted to bring it up because it did influence the management of this patient. There are many, 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 many. This is an entire chart of all the different diagnoses. If you're very interested, then I will give you a link at the end that will actually show you a video that you can pay more attention to. But it's an interesting area, and I just wanted to flag it. So on to some of the meat of what we're going to be talking about. So chest pain, as our chairperson has quite rightly said, Dr. Okello, there are hundreds of chest pain diagnoses that we could pay attention to. But what we do in the emergency department with our sick patients is what are the ones we must not miss. And I would encourage you to imagine that your patient could have every single one of these until you have looked for it and ruled it out. Okay, so I'm going to call it the 7 deadly chest pains of the presentation in the emergency department. Okay, so the things I want you to think about are acute coronary syndrome, esophageal rupture, pericarditis and cardiac tamponade, pulmonary embolism, aortic dissection, pneumothorax, and pneumonia. And I take point of a comment that was made very early on in the presentation from one of the audience members. Acute chest syndrome is possibly something that you should be considering in that subset of patients that have a history of sickle cell disease. So you could add that on. Very briefly, acute myocardial infarction. We all know the classic pain that people come in with, yes? I'm clutching my chest. It's like an elephant is sitting on my chest. I am sweating. I can't breathe. You know, I don't think there is going to be too many people that will miss the classic presentation of chest pain. Usually it's going to the left arm, to the jaw. But what if that patient comes in and says, actually, my pain is radiating to my right arm, or my pain is radiating to both arms? Does that make myocardial infarction less likely? Actually, it doesn't. Okay, so when you look at all of these studies that have looked at myocardial infarction, or people that end up with the diagnosis of myocardial infarction, having pain radiates to both arms with those other symptoms actually increases the likelihood. So don't discount it just because it hasn't come as the classic chest pain. All right. The other important part of this to remember is who have the vast majority of these studies been done in. Yeah. 70-kilogram males from high income settings. So a lot of people with different gender or different race will present with atypical symptoms. So if you have someone that has risk factors that is presenting to the hospital, because we know people often, they don't visit the hospital just for fun, usually, yes? So if they're coming to the hospital for a reason, take it seriously, even if it isn't the classic story of an acute myocardial infarction that the textbooks tell you. In terms of esophageal rupture, now, this is one that we often don't think about too much, but can happen even in a young, healthy person who has been on a night out and has binged and then has vomit, 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 or someone that has an obstruction in their esophagus and they've got vomiting against that obstruction. So anything that raises significantly that intraesophageal pressure can actually cause rupture of the esophagus. And then what happens when you rupture the esophagus? Air comes out, but what else? It's your gastric fluid. Your gastric fluid would then seep into your mediastinum. And just picture this, picture hydrochloric acid digesting your mediastinal contents. This is a very critical diagnosis and you do not want to be missing it. So if you think about it, you are going to look for things like subcutaneous emphysema. You are going to do a chest X-ray. But if you haven't thought about it, you're not going to be looking for those things. So make sure you have this in the back of your mind. Cardiac tamponade. This is probably something that is a lot more common in this setting than I would see in my setting, largely because of the different prevalence of disease. So obviously people will come in with a pericarditis, it'll set up an inflammatory response leading to the effusion, leading to, if it's too big, cardiac tamponade. So again, if you were called as the ambulance officer, asked to transport this patient, you are really going to want to know, is this just a simple pericardial effusion or is this a tamponade? And can I take them 6 or 7 hours down the road to Kampala? Are they going to make it?
No.
How do I best prepare this patient? Yeah. Trust but verify. If you've been given that as the possible diagnosis, do an assessment. Make sure you're not going to get caught unawares. An aortic dissection. This is a tough one. Yeah. So again, a little bit like AMI. Aortic dissection in the textbook, it is ripping chest pain, radiating through to the back, crossing the diaphragm. I think I have had one person in my career that has given me the textbook description of an aortic dissection. People do not read the textbooks and it is very unusual, or you're less likely to get that as your description for these patients. So it is a tough diagnosis to make the vast majority of times. So again, if you are not thinking about it and you are not looking for it, you are likely to miss it. So this is such a problem that some countries have actually launched campaigns. So the United Kingdom, after having so many mortality and morbidity meetings about aortic dissection, actually had to make a very purposeful effort to get people to think about aortic dissection to try and stop this epidemic that was occurring. So what we can do, and in fact, what seems to be the most common presentation or way that aortic dissection is getting picked up these days, those who are lucky enough to have access to an ultrasound will look at the heart and go, that's something's not looking right. I don't necessarily know what it is, but they've got chest pain, they've got severe pain, and their heart doesn't look right. Could this be? So that's a thing. And then, of course, doing your differential blood pressures as the nursing staff, if you are sitting here with someone, you would be like, I wonder. And imagine if you could give that information to the doctor that's looking. It's like, doctor, did you think of? Yes, it's a very useful way to approach a difficult diagnosis to make. Pneumothorax, again, I think a lot of you would be experts in diagnosing pneumothoraces, but there again is a range. There's the asymptomatic patient that comes in with pre-existing, say, bullae or a connective tissue disorder, and then there's the people who come with pleuritic pain and, decreased air movement on one side, to the patients that are trying to die from a tension pneumothorax. So again, hopefully we can catch them at that pleuritic pain stage and think about it. But you can absolutely have someone sitting in a bed in your emergency department with pleuritic pain, and it's not unless you're looking for those decreased movements, hyperexpanded chest, decreased sounds, that you're actually going to be able to rule in, rule out pneumothoraces. And then pneumonia. Really, not much that I'm going to need to say about pneumonia to this audience, I believe. It's a very highly prevalent disease within this population, but not everything with a fever and shortness of breath and a cough is pneumonia. So again, this comes right back to the beginning. Don't stop at the first possibility, because if I showed you this X-ray, okay, you could very easily think that this wedge-shaped opacification is the result of a lobar consolidation from a pneumonia, when actually this is a wedge-shaped infarction from a pulmonary infarct or a pulmonary embolism causing an infarct. So always think there may be more than one explanation. Have you looked for it? Have you checked for it? Right. Skills break after that little talk. So I'm going to ask you one more poll from the audience. Which of the following correctly pairs the oxygen delivery device to the amount of oxygen that gets delivered to the patient? Remembering that FiO2 means the fraction of inspired oxygen. Yeah? We use oxygen every day. We have many types of devices. How do you choose which is the best device that you should use for the patient sitting in front of you?
Yes, our listeners, we have a session of poll on your screen. Could we please respond to that? At least every medical professional has ever used an oxygen delivery modality at some point in life. And you're expected at least to know the reason as to why you are using one, which one and at what time. At least we can give good responses here. Very happy there is a shared view of which ones to use. Almost all of them are getting responses. Could you bring that? We are doing so well so far. And the Seed Global team, the ECHO, is really very happy for your responses. That means you are learning a lot. You are really doing so great. And any of the members in Seed Global in here today would be happy to have all of you, the audience, to manage their relatives at some point. We are very happy for that. We have at least 30 seconds to get that done. Could we give responses? Yes, thank you. You're bringing in. We have about 15 seconds. Let's continue giving our responses. As others also continue giving you questions in the chat part, type in there your questions. I've seen a number of them. They'll all be responded to appropriately, and you'll be happy going home to have attended the best session of emergency response to patients. Thank you very much for the responses. Could we get back to the presenter to continue giving us more information on the management of these patients using this oxygen delivery modality? Thank you.
Excellent. All right. So now we will see the answers. Right. Let the computer catch up with me. It's giving you extra time to think. So you and me sitting here right now, we're breathing oxygen on room air at 21%. So everything we are doing to add oxygen adds to that 21%. Now, nasal prongs, you can run between 1 and 6 liters. After that, it becomes very uncomfortable and very ineffective. So really, nasal prongs can only deliver an FiO2 of 24 to 44%. a simple Hudson mask or face mask can be the next step up, and it will run from 6 to 10 litres a minute, giving a 35 to 60% FiO2. Because remembering there's leak that is going to be occurring around. These are not 100% seals. Similarly, for the non-rebreather, which is probably the highest that the vast majority of people would have access to in their clinical settings, and that is run at 15 litres a minute and will give anywhere between 65 and 95%, depending again on the seal. Now, Mr. Joseph Batista and I were talking just before. What are the most common errors that you see with people who have a non-rebreather on their face?
Okay, well, thank you so much. It's a great question. You see, in hospital, when you're managing these patients, there are a number of things that we follow. And though there are some protocols that guide us, sometimes also errors happen. So when using an rebreather, some of the mistakes I've witnessed is we give again too low oxygen rate. For example, we know very well that non-rebreather mask, it gives above up to 15 liters, but you find out that maybe you are using to give a patient 3 liters. Okay, that's too low. Why we have used nasoprongs. So sometimes we use incorrect masks. Okay, we have children, then we have neonates, we have adults. So each of these people have got their own mask that fits them. But you find out that you may be again using a child's mask to an adult or adult mask to a child. So it's common. So it may depend on the many factors. Maybe you don't have the proper size at the time. Okay. We also have not monitoring patient response. So when we give oxygen, you will monitor patient response. How are they responding? Do I need to increase? Do I need to reduce? From Dr. Julia, when she was presenting our case here, we saw that this patient had a need of 10 liters. By the time they were being, as we went on, the oxygen demand reduced to 8. So how would you know this? Is through monitoring, reassessing this patient as the care goes on, continues. It's common also that sometimes we give oxygen, which is not humidified. Okay? Which makes this patient very uncomfortable. When you give oxygen which is not humidified, it dries up the patient's mucous membrane. So it may be helping, but again, it's causing more discomfort in this patient. So it is important that I know hospitals have got protocols, have got ways how to help us, minimize these mistakes, and following them, it's very important. Yeah, so those are some.
So thank you very much for those insights. I absolutely agree. Size the mask appropriately. Make sure if you're on a non-rebreather, the reservoir bag is actually full of oxygen. Yes. Yeah, and that the patient is on 15 litres. If you have them on a non-rebreather, they should be on 15 litres. And titrate. Choose the oxygen that you're targeting, okay? You also may have seen these in your drawers in your hospital setting, and I would recommend that you perhaps have a look at and a play with the Venturi devices because they are also a useful way to even finer titration of your oxygen delivery. And then finally, often in a more ICU type setting, you might find these humidified high flow oxygen devices, which are excellent if you are trying to deliver a small amount of P, because you can actually titrate it right from 21% up to 100%. And it's as good a step as you can go short of non-invasive and invasive ventilation. So in the commentary, I saw you can go up to 70 litres a minute. Yes, it very much depends on your protocol. It's usually 1 to 2 litres a minute per kilo per minute. So just be familiar with your equipment. So back to chest pain. So we've talked about some of the historical and clinical features. We talked about some of the ways that you can try and decide which is more likely. What are the other things that we're going to use to be able to tell the difference between each of these 7 deadly chest pains? There's this thing that we call pre-test probability. Now, I am not very good at statistics. I am sure that there are some people out there that are. But pre-test probability is a really important concept for you to understand, because it's the likelihood that a patient has a specific disease before any tests are done. And I know one of the comments early on in the discussion was, well, we have limited resources. How do we know? This is why you have to have a good clinical exam and a good thinking systematic process so you can develop a reasonable pre-test probability for each of your diagnoses. It allows you to decide whether or not any further testing should be done. It allows you to identify which test you want to use. You have a certain amount of money that you can spend, so what are you going to spend it on? And it also allows you to revise the probability of your disease depending on the results. So does this test actually increase my probability, or has it decreased the probability? Now I need to rethink my diagnoses. How do we do this? Well, prevalence from studies. So researchers out there, this is a shout out to you. We need more studies that look at the prevalence of disease states within your population, because it really does make a difference. As I mentioned before, in my setting, the risk of TB pericarditis is much less than the risk of TB pericarditis when I'm looking after patients here. So that changes my pretest probability significantly. You also develop data sets about what the most important symptoms and signs are to elicit, and we talked about those as we went through the 7 deadly sins, chest pains. There are also some resources out there that I would suggest that you have a look at. There's this fabulous series called the Rational Clinical Exam series, which actually looks at all of the particular questions, say, in this case, pulmonary embolism, and it looks at the sensitivity and specificity of clinical exam findings and tests, etc. So it's a nice resource to refer to. Your clinical judgment, it actually goes a long way, and we'll come to that in a little bit of a moment as well. And your clinical judgment will absolutely improve with experience and time. So clinical judgment of an intern is going to be very different from a clinical judgment of a specialist that has been working in cardiology for the last 20 years. Yes. And then finally, clinical prediction rules. So clinical prediction rules come from research again, so they're very important to know what fed into to develop those clinical prediction rules. And we've already talked about one in this particular discussion. We've talked about the Wells criteria. Now, I think you all answered this poll, so check, and you can check your own performance here and see whether you are right. So there are these 7 particular features that go into looking at whether this patient has, or how likely this patient is to have a PE. So this develops your pretest probability. So for our lady, she had signs of DVT. We all thought it was probably the most likely diagnosis. I was watching that chat. I saw PE come up many times. Her heart rate was greater than 110. And she had actually traveled all the way from Yumbe to, and I hope I'm saying that right, to Mbarara the day prior. And she'd also having streaks of blood in her sputum as well. So this actually puts her into the high risk category. So high risk means that she has a 40% chance of PE, and that's in a relevant population, so the ED population. So that means we're on the right track, yes? So we need confirmatory testing. There are so many things that we can do, but that's going to be very much limited by the setting that you're in. The most common ones that I have put up there, not all of them are going to be available to you. I'm going to talk for a moment about D-dimer, because anyone that has had to suffer through one of my lectures will have had to have heard my rant on the D-dimer. So D-dimers are, I see them done very frequently. But if you have a patient who you think has a PE, has a high pre-test probability that has a PE, the D-dimer actually doesn't change the likelihood that this patient has a PE. D-dimers are elevated in sepsis, they're elevated in anything that causes enormous amounts of stress in the person. If this was just a pneumonia, the patient would have a D-dimer elevated. So please, D-dimers are useful if you're like, I'm not sure. Could this be a PE? They're pretty low risk patient. If you then do a D-dimer and it comes back elevated, then you are led down the path. So your pretest probability has been changed by that test, and you're led down the path now going, I have more evidence now to show me that I should be testing for a PE. So use it wisely. Don't spend people's money unnecessarily. Keep it for the patients where it's going to make a difference. And then the last little bit I'm going to talk about is the treatment for PE. So the treatment for PE has changed across time. And I think it really matters depending on how big the PE is as well. So we have small PEs that go out into your lung has filtered them and they've gone into the periphery and they cause pleuritic pain, they cause a small degree of hypoxia. Those are what we call subsegmental PEs. They are not causing hemodynamic compromise. For those, a low molecular weight heparin or a direct oral anticoagulant would be more than suffice. The evidence has now shifted in the massive to submassive PE area to suggest that we should be a lot more aggressive about how we manage these. So using systemic thrombolysis like streptokinase, I think would probably be the most commonly available in this setting, but watch this space. I do believe there is some momentum for getting Metalise available. So providing that in the right patient can actually help dissolve the clot directly and break it up from being that saddle embolus that we saw on the image that Julia showed us into small little clots that aren't as hemodynamically significant. If you are getting your patient transferred to a higher level center, maybe one of the reasons that you are transferring them is to get something called catheter-directed thrombolysis, where they feed a catheter directly into your pulmonary artery and shoot the thrombolytics or the thrombolytics directly at the clot and dissolve it at the site, so that you don't have to expose the whole body to all of those blood thinning medications. And then some fancy places will actually go in and grab the clot and pull it out. Regardless of any of those treatments, you are also going to do exquisite supportive measures as described by our nursing colleagues. So the long-term consequences for survivors of PE are not insignificant. They've had one PE, that puts them at higher risk of other venous thromboembolic events. they can get chronic changes. So chronic leg swelling and pain, also known as post-thrombotic syndrome. And because of that stress on the heart and the lungs, you can get pulmonary hypertension, which can significantly impair your quality of life because you will become short of breath on exertion, and it will decrease your long-term survival as well. In terms of mortality, deaths is really kind of difficult to estimate, and I'd be interested to know if anyone has any better information on this, but I couldn't find a detailed study that really talked about our setting. But there is a significant mortality associated with your submassive and massive PE, and premature death, clearly, as I've already mentioned. The one study that I did find from Africa was a meta-analysis looking at, a systematic review looking at, I think something like 7 or 8 different countries. And there was a big variety of mortality, everything from 7% in Togo to 41% in Angola of patients presenting to the ED. So it is not an insignificant cause of death. So I think I am going to bring my presentation to a close at this point. I have a few extra bits of information and resources, as I said, when I spoke about the YouTube video that I was going to give a link to, and we can put that in the chat. But please, when you are looking at someone with a chest pain, make sure that you're not closing too early on one diagnosis, and you're checking that you have thought about and ruled out all of the other possibilities. Thank you for your attention.
Thank you very much, Dr. Tracy, for the very detailed presentation that possibly could change patient management in terms of approaching patients who present to us as emergency with the chest pain. At least everyone has learned that. I'm sure it's going to change patients' management to the best. And our diagnosis will also improve for the betterment of the patient. We are really chasing time so much, and we're doing so well in terms of time management. The next session will be discussion, that is questions and answers for what we have presented, and that will be brought to us by one of the greatest emergency physicians you'll have in the country, if not East Africa as a whole. That is Dr. Baluka Koni, who will take you through this. At least you are blessed today to have the best presenters. Thank you very much, Dr. Koni. Could we welcome you? The audience are really very happily waiting for you to give them the best.
Thank you, Doc. I've tried to answer most or all the questions that were brought through the chat. Unless if there is someone who has raised their hand up, but currently we are answering in the chat.
Okay.
Yeah.
So for our dear listeners, you can put up your hands and unmute and ask a question as others continue putting in the chat down there. And we have about 10 minutes to do this. This is quite a good amount of time to help us learn everything. Yes. Let me hope our questions are being answered and we are getting satisfied with it. There's a question in here. Someone is asking for the CBT link. Sure. I think has been shared already. Someone asked because the senior nurses who work in ICU was presented. Is it true that the patient nursing care plan of the nurses are extracted and put in the patient's file? Francis wanted to know. I don't know. He's getting scared in managing a patient in ICU. I don't know. But all is well. Don't worry.
I can answer that. Francis, I want to say that during patient care, we do in as we call a multidisciplinary approach, and everything which is done is documented. So if you do anything and it's not documented, it means nothing is done. So nurses' care plan is part of patient care. It's not only for you, but even for the physician, for the intensivist, or any other person who will come and see what you have done as a nurse. Then they add on what you have not done. And remember, documentation is very vital. It does not only help you in the care of the patient, but also actually we use it for even research. For example, today we are speaking about patient with PE. You'll find out that when someone's carrying out research, they can maybe request to go through the past care plans or what nurses have been doing for this patient. How are they managing? What were the common concerns among patients? So everything, in summary, everything we do, okay, for the patient, it is documented in patient's file. Yes, thank you.
The next question is, doesn't morphine have respiratory depression as a side effect, and wouldn't it worsen the patient's breathing considering they are already having low oxygen saturation? So I think this has been answered here. Just adding more thing, maybe oxygen saturation, like they have talked about, and the work of breathing are two different things altogether. So any patient who presents with the increased work of breathing, one of the things you'd want to do is reduce their work of breathing, because they will have exhaustions of their respiratory muscles. And when you do that, they can get into hypoxemia, because there's going to be increase in the detention of carbon dioxide much more into their blood. So one of the things you want to do in these patients, the respiratory rate had increased. So you want to you want to reduce the work of breathing as much as possible. I think that was also one of the questions they asked. And Dr. Coney has also tried answering very well in there. The next question, someone wanted to know if they can go through the interpretation of the ECG. This maybe the team will look through it, because time for now might not be the best. Someone is asking, how do I organize a transport means for someone at a very low facility of Health Center 3? I think at Health Center 3, every facility, and I think every organizations have their own. So maybe Mr. Joseph, the ambulance senior, can talk about that.
Just a minute, I was noting about the ECG. At a later stage, I wanted to tell someone that if you want to learn more, you can actually come to our center. You take an advanced life support course. So there is plenty of time to learn that. Please come again with the question.
The question is, how do I organize for transport mean for a patient in an emergency situation from an Health Center 3 that they don't have ambulances?
Okay, that's some sort of a system question. But all I know that all these districts are now linked with regional representatives from Ministry of Health. So usually when you are struggling, please call the regional rep. They will be able to organize. And there are also private providers of ambulance services. You could also tap, there is a team from rescue.co who are trying also to provide ambulance services world over. So I can also share some contacts on many of our service providers, ambulance services.
Thank you, Mr. Joseph. The next question in here is Willie wanted to know, how do I approach a patient who has suddenly collapsed after raising up or waking up from sleep, or have sat for long hours despite normal blood pressure, BP taken?
Oh, that's a question for me.
It's a question thrown to the team. Maybe Dr. Connie could respond to.
Yeah, Dr. Connie, I think you answered in the chat. Did you want to explore your reasoning there? Because I fully agree with what you've mentioned.
So there are several causes of acute collapse, and one of them is postural hypotension. Definitely, the patient will have a normal blood pressure measurement post sitting up or post standing up. Right now, that was not the point, but this is a patient we need to go further and assess. We don't have a straightforward answer for them. It's not one diagnosis that is written and carved out properly. So this is a patient I would want to take in, maybe have a physician's review, have several investigations done, and you get to the bottom of the reasons as to why they actually get postural hypotension. Because it shouldn't be happening. It normally doesn't happen to normal people. So if it's happening, this is a patient I surely want to take to hospital and have them fully assessed. Yeah, that would be my response.
Thank you very much, Dr. Connie, because this is a patient that is standing up and changing position. Is postural hypertension, like she has talked about. You want to assess for very many things what could have caused. The patient could have not eaten for long, I sat for long. From your question, could be hypoglycemic. You never know. So there are very many things in this question. So could be specific. Maybe someone is talking about in most, if not all government health facilities, radiology department is always not open on weekends, but operates on call. What happens when there is an emergency? That's question one. Question two of that very part, in the registration form of this CPD, and I think that one has been answered already in that. So it's asking maybe the emergency team, the imagings and what don't work. Maybe someone can put something around that.
I don't know if someone from ministry is online. We are able to answer that. Why? And we should ask ourselves, we are 300 plus on this call. Why don't you open up on weekends? Why do you operate laboratories on call? I don't know. Maybe it's a matter of attitude or.
Yeah, look, I think patients get sick 24/7, and if you, in an ideal world where you have infinite resources, then it would be fabulous to be able to have that corresponding services. But internationally, this is an issue, and it is a systems thing that needs to be looked at from a higher level to see how it can best address and serve the population. I agree.
Yeah, so I think that is well answered. That is also another system issue. Maybe the different organization, depending on where it is, can answer that. So in this kind of session, we're looking at emergency approach. So that is now a system issue. You don't enter into system so much. So then the next question maybe Dr. Connie could also answer is, why did they choose to have levofloxacin in the first management of this patient who presented? Yet the GeneXpert results were not yet out from the new guidelines of the management of community-acquired pneumonia.
So there is something called a doctor's preference. I do not want to use that because we all know we've mismanaged antibiotics, or all through. So probably I didn't manage the patient, so I cannot give you the reasons as to why they used levofloxacin. Definitely, levo wouldn't have been my first choice if I was managing this patient, but also the doctor has reasons as to why they chose levo. So we should, I think, as we go further in our EDs, in our health center 2s, health center 3s, we need to have these guidelines printed and placed somewhere visible. Medicine is not, I know it all. We always go back to the book. We always have those guidelines to help us run through decision making as fast as possible. That will help both the physicians, doctors, clinic officers, and the nurses. Thank you.
Yeah, just maybe adding small on Dr. Connie's voice is most likely, like she has said, it's a physician's choice and the availability at that point. Though the guidelines for our listeners mainly talk about giving the penicillins, which most commonly amoxiclav is our first line from the new guidelines, and you do your typical cover for education purposes, which is either a macrolide or you give a tetracycline, most commonly doxycycline, depending on the patient you are having at hand. Thank you very much. Looks like questions are now getting over. Yeah. Okay, thank you very much, our listeners, for this. I know we can't answer all the questions. Could we had our pre-tests before the start of the session, so we are going to the next, which is the post-test, to see how much we have learned and how much you have gained from the presentations for the betterment of the management of your session. It's going to be displayed on your screen, there. Thank you. In a few minutes, it's already there. Could we try answering that question, please? Yes, please. The question is on there. Some few minutes, some few seconds that we get done. Could we please respond to that? Very good response so far. That means people have learned. This was a question that was presented before, and there was a very diverse kind of answers, but people are now restricting it. That means we have really understood what we could do to respond to patients with chest pain. Seriously, people have learned. You can see from the responses, everyone is impressed about this. We have really learned. About 1 more minute to this. Please, let's try. Give your response at least. Responses are coming. We are very happy to see that at least everyone is trying to attempt the questions that have been displayed with a very good improvement from the pre-test polls that were put. In here, we are doing so well. About 15 more seconds to go. At least put your response. Show that you have gained something from this session. We are very happy for your attendance, and your gain is our benefit. Thank you very much for your responses. Get back to our experts to give their remarks on this and for what you need to take home as in response to patients in emergency situations with chest pain. Thank you. We begin with my senior in response, that is Mr. Joseph.
Yeah, from this executive session, remember to prepare enough, prepare well, always ask when you're not sure. And for PE, if it's really a big plot, please prepare the fastest means available.
Yeah, thank you very much. I told you, Joseph, very many today. Another Joseph.
Thank you so much, everyone, for listening and the experts on board. I want to thank you for attending. But if you are a nurse or any other person, what you should put in mind is that when we are caring for patients, you are not doing it as an individual, but we are doing it as a team. The hospital has all these people on board because they contribute to patients' well-being. And also understand that despite that you may have several patients with the same diagnoses, medical diagnoses, just understand that they may totally have very different nursing diagnosis or nursing needs. So continuous assessment, planning is very important, and that one should stay with you. Thank you so much.
Yeah, thank you very much, Joseph, the expert. Could we also listen briefly from Dr. Julia?
So my key take home is assess the patient, follow the A2E thoroughly, and manage and reassess again, and do not anchor on the diagnosis. Always keep your mind open. The patient that I presented today could have gone as community-acquired pneumonia and deteriorated and even passed away if nobody else have put in mind the pulmonary embolism. So do not anchor, keep your mind open.
Thank you very much, Dr. Julia, for that very good remark. Could we now come to the most senior that will now give you everything that you need? That is Dr. Tracy.
I will keep it very, very short. Yes, and I would second. Keep your mind open, be systematic, work as a team, and as part of our skills session, just reinforcing to choose the right oxygen choice and use it appropriately when you're managing your patient. Thank you.
Yeah, thank you very much, our listeners, for listening to us. We are very happy to have had you to attend to this. We are very grateful. We welcome you for the next session next time and invite others to attend next time. Thank you.
And just quickly, I think I'm going to run through the final answers. So for the first question on the quiz, when considering the important diagnoses, costochondritis really is down the bottom of your list. Yes, it could be something, but it is not going to kill the patient. So have it way in the background after you've dealt with everything else. In terms of the top 3 priorities, the patient was hypoxic, they were in 8 out of 10 pain, and they had this, what we thought at the time was a fairly borderline blood pressure, but actually turned out to be a significant blood pressure hypotension in the context of their normal blood pressure. So oxygen, analgesia, and fluids was the correct choice for that one. In terms of the key investigations, now this is a little bit controversial and a little bit, manufactured, but really your aim is to rule out infection, to rule out AMI, and to rule out or rule in APE. So we were thinking CRP, chest X-ray, and an ECG would give you a lot of information if you only had 3 to choose from. In terms of the Wells score, recent surgery and immobilization is the only one that actually exists as part of those 7 criteria. And then diagnostic momentum, I'm very happy to see that people recognise that a previous diagnosis that's accepted and carried forward without anyone giving it a second thought or going back and re-examining the patient is a significant cognitive bias. And the last question, the vast majority of people here also managed to identify that a simple mask run at 6 litres delivers about an FiO2 of 35 to 40%. So well done, team. Good work.
All right, so yeah, we can close down.
Yeah, thank you very much, our audience, for this great session. We are happy to have you. We welcome you for the next session next time, and we continue learning and we manage our patients today very well. Thank you.
Thank you.